Good morning, good afternoon, and good morning, depending on where you are in the country. Buenas tardes, everyone, and welcome to our 10th episode of Pandemia, the series of webinars about COVID-19 and COVID-19 vaccines, focused on directed to the Latino community in our country. My name is Luis Alberto Mares. I am the Director of Community Mobilization Programs at the Latino Commission on AIDS, and today I will be your host and your moderator for this webinar. The series of Pandemia is brought to you by a collaboration between the Latino Commission on AIDS and the COVID-19 Prevention Network, and we've been doing this for over a year. The format of the webinar will be as follows. We have a presenter, an expert in the field that will have a presentation, and then we will have questions and answers. And please, I ask you to write your questions or comments to the Q&A box that you find in the bottom of your screen, so we can read those questions to the presenter as well. This webinar is being streamed on Facebook Live and the page of the Latino Commission on AIDS, but it's also being recorded, and it will be posted at the Latino Commission on AIDS website and will be sent to you by email afterwards. Well, to the webinar. We're living through this pandemic for almost 2 years. It's incredible how time passed by. It's almost 2 years that when we heard for the first time about COVID-19. Much has happened since then, and we've been through the days when New York City, where I am now, was the center of the epicenter of the pandemic, not only in the country, but also in the world. And since then, we went through many things, and at the end of the last year, we had the approval of some vaccines against COVID-19, which continued to the beginning of this year. And through this year, the rollouts of the programs for vaccinations. But still today, there's no more than 60% of the population has been vaccinated in the country, even less in the world. So this fact has favored the appearance of different variants that we know about the Beta and the Delta before. And today we hear about Omicron, which is the new one that the World Health Organization has named. And this has caused the researchers look into it to see if they are more dangerous or more easy to propagate than the other ones, and to see if the vaccines that we have are useful for this. So today we are going to have this overview of where we are right now in the pandemic and about this new variant Omicron. And for this, we have an amazing presenter, Dr. Julie Levinson. Dr. Levinson is a community-based infectious disease physician and health equity researcher. She's an assistant professor of medicine at the Harvard Medical School and is co-director of the community research program at the Massachusetts General Hospital Chelsea Health Center. She received her MD from the Harvard Medical School, completed an internal medicine primary care residency at Brigham and Women's Hospital and infectious disease fellowship at the MGH-BWH program. Dr. Levinson runs an NIH-funded research program in the MGH division of the General Internal Medicine and Morgan Institute, focused on understanding and addressing disparities in outcomes for infectious diseases with attention to HIV and AIDS and Zika infection. Dr. Levinson was the recipient of the El Planeta Empowerment Award, Top 100 Individuals for Latinos in Massachusetts, and the Harvard Medical School Arnold P. Gold Foundation for Humanism in Medicine Award. She is a member of the Latinx Expert Panel for the National Institute of Allergy and Infectious Diseases COVID-19 Vaccine Prevention Network. So, Dr. Levinson, the floor is yours, and thank you very much for being with us today.
Thank you so much, Luis, for the invitation, and to the COVID Prevention Network. It is really such a pleasure to be with all of you. I wish I could see your faces if we were all in a room together, because we would see what a large community and family we have, all working together to get through this pandemic. And so I'm very grateful and thank you all for having me. I'm going to share my slides, but have a couple of slides today, and then really look forward to having a discussion facilitated by Luis with your questions. So to tell you a little bit about my perspective, I spend a lot of my time doing research focused on questions based mostly in HIV, but from the experience of working in our communities, predominantly with Latino populations, we learned so many lessons around HIV as to how to handle the COVID-19 pandemic. And so today I'm going to take some of those experiences and really talk to you about what we know so far in terms of an update for COVID-19, thinking about the Omicron variant. I'd like to first briefly review the virus, SARS-CoV-2, just a couple of slides so that we're all thinking on the same page. I'm then going to give a brief update on where we are with the COVID-19 pandemic, thinking about the globe and the US. We'll talk about this new variant. I'll tell you a little bit about it, Omicron, and what we can do about it. And then we'll have a discussion about your questions. So to talk about briefly the spread of SARS-CoV-2. So SARS-CoV-2 is the virus that causes the disease called COVID-19. And what we know now, as Luis said, we're almost 2 years into this pandemic, that it is spread from person to person, mostly by respiratory transmission, respiratory spread. And this transmission is mostly through close range contact within 6 feet. But we do know that in certain episodes, like in speaking, loud voices, coughing, or sneezing, these respiratory droplets that have moisture, but also virus, can be spread quite far. And here you see this example of here's someone sneezing, and the sneeze traveling 7 to 8 meters. And that explains some of these very transmissible disease outbreaks with SARS-CoV-2, where we have seen, for example, in loud restaurants, bars, congregational settings where they're singing, that the virus can spread at a greater distance. SARS-CoV-2 can infect not just the lungs where we breathe, but organs all through the body. And I show here all the way on the left, from the nose down into the lungs. The ileum is in the small bowel, so in the abdominal area, which is why some people have diarrheal symptoms. The heart, the eye, the liver, the bladder, kidney, pancreas, brain, prostate and testes, and can cross the placenta. And that explains why this is not just primarily a respiratory disease, but also can have these other symptoms across the body. So that's a brief review of COVID-19. I'd now like to get us up to speed where we are as of December 16th, 2021. So if we just think back to the beginning, and this is a map of the United States, and this is February 1st, 2020. And you see Alaska, Puerto Rico, and the mainland US, and it's all blue because we hadn't seen COVID yet, or SARS-CoV-2 cases. And what you'll see is the map begin to change. So blue is low level transmission, yellow will be moderate, this pink is substantial, and red is areas of high transmission. So that by April 1st, we saw these pockets of outbreaks. And then by July, really massive transmission across the United States, affecting particularly areas that had lifted public health measures or had not instituted or had incomplete mask mandates and closures. And we see the areas most affected in the red. And then by December 1st, so 1 year ago, the whole entire country essentially being in an area of high transmission. Over time, there was some improvement. And in fact, you probably remember there was a lot of hope about having barbecues during July 4th of last year. But what we began to see, so you see, most of the country yellow from red, but by August of last year, back again, nearly the entire country in an area of high transmission. And this mapped on to the subsequent surge with the Delta variant, which was a new kind of mutation in the virus, which was a form of SARS-CoV-2 infection, which was very highly transmissible. And so there was more spread again. And now what we see, December 2nd, extensive transmission across the country. in mostly high areas. And we've seen some moderate levels down in the south around Florida and lower parts of Texas. So I'm going to transition now to talk a little bit about Omicron, but I wanted to describe how this variant was identified. And so the way the chronology or the time course unfolded was that our colleagues in South Africa, working very hard in looking at the case counts and the epidemiology, so tracking the amount of infection in the country, began to see that the amount of infection began to rise in early November. And the laboratories in South Africa, and we owe a lot of gratitude to our colleagues abroad, began to investigate, and this was about November 14th to 16th, what was potentially different? What was the genetic code of the virus that was circulating at the time? And what they found was that by mid-November, the SARS-CoV-2 virus was different than before. Interestingly, by November 23rd, Botswana, South Africa, and Hong Kong had all uploaded to an international database information on a new strain of the SARS-CoV-2 virus. And so what was striking was that by November 23rd, there was evidence that a new variant had gone outside of the African continent and had involved multiple countries. And this variant of concern was named B11529, or the Omicron variant. I'd like to show a little bit more about what the case count looked like in South Africa. These are slides produced by the Centers for Disease Control in the US and based on South Africa data. And what you'll see in the overall, you see these surges, 3 major surges, and the red line represents one of the provinces, Gauteng. And by mid-November, you see this spike, this little climb that began to occur that caused concern by public health officials. And what they noticed was that while the initial surge had been mostly Delta virus or the Delta variant, by November, there was a new form of the virus that was causing the infections, and this was the Omicron. As if you follow this red tail all the way on the right, what you'll see is that the rapid rise, so the vertical axis is the average number of daily cases. You'll see it rising. This is December 2nd. This is December 4th. So what do we know about the variant? The variant has many new changes in the virus, and these are approximately 30 mutations clustered around what's called a region that codes what's called the spike protein. And so why does this happen? Why this variants in viruses are something that is expected. When you have a lot of virus in the body, just like that can happen in HIV, viruses can reproduce, and the genetic material, which are the building blocks of the virus, can mix together. The more virus in the body, the more chance, and in the community, the more chance there is for mixing. And that's why, just like in HIV, we want individuals to be able to take their medicines so that the virus in the body goes down, and that helps prevent viral resistance to medications. Similarly, we want to be able to lower the amount of virus in the community so that there's less chance of infection disease, but also less chance for these mutations. The mutations really can affect the way the virus interacts in the body, particularly with the immune system. And we're really in the early phase of this new variant, but there's some things that we do know. or at least there's early evidence, and there's a lot that still needs to be figured out. The mutations may cause the virus to be more easily spread from person to person than the Delta variant. And what we're seeing is that the Omicron variant is likely much more transmissible and can resist the effect of the vaccine in those who are vaccinated or the immune system in individuals who have been infected before. And there may be some effect on treatment. Currently, as of yesterday, the variant, so the Centers for Disease Control, working with academic institutions and other laboratories, are doing special sequencing of PCR tests that are positive. And what they have identified is now Omicron is in at least 36 of the United States and 77 countries. Is the variant makes roughly 2% of all of the SARS-CoV-2. So we still are mostly dealing with Delta, but it is possible, based on the expectation from the Centers for Disease Control, that this new variant will be the dominant variant by the new year. But this is something that remains to be seen, and we will get more information as more of the infections get special typing, so we can understand whether they're related to the variant or not. What else do we know? Omicron has infected individuals who are fully vaccinated and individuals who have recovered from the Delta variant who've been reinfected. We also know that this variant reduces the effect of a 2-dose mRNA vaccination. So for example, 2 doses of the Moderna or 2 doses of the Pfizer vaccine. So it does reduce the protective effect on the immune system and the overall vaccine protection. However, the vaccine, and especially boosters, can protect against the worst outcomes related to SARS-CoV-2. And those are hospitalizations and death, and getting especially getting the booster, you can bring the immune response back to those effects that we had initially seen with the wild type virus. We're awaiting much more data on signs and symptoms and essentially the disease with Omicron, but our early evidence, particularly in South Africa, indicates that the disease appears to be more mild. And I wanted to show, this is another slide produced by the Centers for Disease Control based on data from South Africa. But what this slide summarizes are hospitalizations, which in the blue bar, the yellow line represents individuals who are really the sickest, those who are hospitalized and with a breathing tube. And the orange line represents the daily case rate. And what you can see is as we move all the way to the right on the slide, as the daily case rate has markedly increased in a surge, the hospitalizations have increased a bit, but the numbers of individuals who have been hospitalized and ventilated have not surged with the same direction, giving a small signal that this disease may be more milder than the prior strains, but we still have so much more to learn. I'd like to conclude by thinking about what we can do. And there is a lot that we can do to prevent infection and poor outcomes from SARS-CoV-2, including Omicron. So number one, getting a COVID-19 vaccine still is key to prevention, and particularly getting a booster. The vaccines are safe and effective and have been evaluated in very large trials. Other things that we can do to stop COVID-19 still remain the same. Washing your hands often with plain soap and water, covering your mouth and nose with a mask when around others, particularly in indoor settings, and avoiding crowds and practicing social distancing. I think it's important, particularly those of us who come from working in HIV, we understand the intersection of socioeconomic disparities and disease and how these come together in like an eye of the storm, and many of the vulnerabilities that put individuals at risk for COVID-19, preceded COVID-19. They were the fault lines and the oppressive scenarios that put people at risk, and those exist and in many senses have gotten worse. And so how can we think in a comprehensive way about taking care of our communities? It's important to look at the data in a very local way. There are still strong racial and socioeconomic disparities in vaccination rates, and we need to think town by town about how best to address under vaccination. Children's vaccination rates still lag adults and still vary based on towns, particularly those most affected by COVID-19. Housing and food insecurity were a problem in frontline communities and remain a problem, if not worse, and are still important in addressing. COVID-19 outbreaks in schools. We know how important it is to keep our children in school, particularly for mental health and to help their healthy development and growth. We need to continue to have access to testing, particularly opt-out testing, so all children and teachers can be tested and be able to remain in school. When we think about health information, we know that health information is best when it's in a form that individuals relate to and understand it well. And so having health information that is tailored to our most affected communities is important. And we need to continue, as we've learned in HIV and many other conditions, as we think in public health. Mental health is so important, and particularly in our children, as we're seeing a general mental health crisis in our population during the pandemic, but particularly in our young adults and children. And so I raise these issues because we know vaccination is important, but there's so many areas that we still have to fight and address, areas of equity that help improve not only risks for COVID-19, but overall health and well-being. So I'd like to thank you for your attention, and I welcome your questions.
Thank you very much, Dr. Levison. I can see some questions here. Darian Leda, he said, can you speak about where Omicron might, I think you touched a little this already, might have originated from? What is the first, why was it first discovered in South Africa, or is another country, as other research suggested? With that, can you talk about the discrimination of the travel ban from African countries with this assumption that it came from Africa, because in the future, this could happen in a Spanish-speaking country in which Western nations will discriminate the same way? Right.
Well, you know, in the what was identified pretty quickly, I had mentioned, you know, by November 23rd, the Omicron variant was seen outside of the African continent, and it just explains, you know, what a global community we do live in. The situation in South Africa is a little bit different than the United States in a lot of ways. The uptake of vaccine was less than 30%. The individuals who were identified in having Omicron tended to be a younger population, large university population. There's a larger proportion of individuals living with HIV. And so when the immune system is lower, there is higher virus in the blood. Just in the case with HIV, similar, it's very difficult to for the body to control the virus, control infection. And so one of the thoughts is that you know, when there is higher level of virus, there's more opportunity for reproduction of the virus and changes in the virus. So these mutations, just like we would see in HIV, similar situation in SARS-CoV-2. I think that the question is such a good one around the travel ban, because we're in the 21st century and we can really get to any corner of the earth fairly quickly. And one of the things that did occur, and my colleagues and friends spoke out, as well as myself, you know, spoke out in terms of the travel ban, initially against South Africa. Our South African partners, as soon as they saw that there was a new variant of concern, were public about sharing this so the world could benefit from this. So I think what we know is that travel bans they can buy some, perhaps a little bit of time, but if you remember from the Dutch, the airplane flight that landed in the Netherlands, they have to do screening before the plane before people get on the plane. By the time the plane had landed in the Netherlands, there were already multiple cases of Omicron. So, the impact of travel bans is troublesome because it can impact stigma and blaming. And in an environment where people are traveling all the time, we need to think about more community-based interventions that really focus on equity, about getting the vaccine out globally. So I think the viewers' concern about travel bans is very well taken in a setting where people are traveling very quickly, and we see the virus much more later after it landed there. We're sort of, seeing a situation that happened days to weeks before. So the travel bans are kind of more coarse measures, and we have to think about greater investments in public health long-term.
Thank you very much. And there's a question from Mireya Alexander. I don't know if you have the list. She wants to know which are the 33 states that are affected. Maybe we can send it by email.
Yeah, absolutely. So I want to say it was Monday, I think, that the CDC published a new report called an MMWR report on some of the initial cases with some of the clinical findings, as well as a map. And so we can give that to you through a link, and you can have access to that publication.
That'd be great. Thank you. Lucy Vega asked about COVID effects mostly in what we have seen in the respiratory system. So if a person is actually positive and has COPD on top of that, can this person survive COVID? If they
Yes, what we know is that individuals who have well-controlled HIV can do quite well with COVID. So it really just underscores the importance of doing the things that we know in general are so important for good quality of life and health, which is having access to HIV care and to primary care, and access to medications, and reducing stigma and those types of barriers that have a negative impact on health, because access to HIV medication can really lead to a very good quality of life with HIV, and also improve outcomes if someone were to get infected with SARS-CoV-2.
You mentioned in one of the maps that you show how at the beginning the pandemic was more the north, and then we went to the south. And it reminds me a lot of how these states of these areas are affected mostly by HIV also. It's exactly the same map. And,
Right.
and then you mentioned that it was caused mostly by social economical factors. And I think these factors also affect the rate of vaccination in those areas. Is there a way that we as a nation, can we do something about vaccination in the area? Or I know it's a lot to ask about socio-economic factors, that we have to work around that, but what about vaccination can we do something to increase vaccination in those areas?
Yeah, I come from a community outside of Boston called Chelsea, which has been heavily affected by COVID-19 and has gotten a lot of news about it. And we are a large population with essential workers, over half Latino, over half foreign-born individuals, and have had a lot of challenges, but has also been a story about resilience. We have some really wonderful community-based organizations who, basically we've done a kind of door-to-door campaign working with community health workers who bring food, masks, help with legal services. So I think, these are what we've learned in HIV is really about the importance of treating people holistically and meeting people where they are. And Ayanna Pressley, one of the representatives in Congress, talked about bringing power to those who are most in pain, bringing power closer to those who are most in pain. And the leader of our community health system in Massachusetts talked in a similar way about bringing testing and the vaccine closer to those who are in pain. So what I mean by that is strategies that really bring the interventions closer to where people are. So it can be as easy as possible, meaning work-based, school-based services, mobile vans, using peers and church leaders, religious leaders, people who are respected, who are really bringing this important public health information into the family of the community. So it's not something from outside, but it really becomes a community and a family intervention. And that requires real local work, but as well, federal and state support.
Yes, I can say, like, here in New York, I mean, not only my organization, but several organizations are working on their own, trying to increase awareness about COVID-19 and the importance of vaccination in our communities. Mike Clifford says, there seems to be a drop on the hand washing and social distancing messaging. Wearing masks have been the focus. Can you speak on the continued messaging on not outside the mask wearing? Why aren't we proposing again that wash your hands and maintain distance? It seems like people kind of forgot about it already.
Yeah, well, one of the reasons that there's so much investment in vaccines is that they're very effective and they can last a long time. But we do know, take for example, flu. So when before we even had a vaccine for COVID-19 and we were relying on masks and hand washing and social distancing, cases of influenza really dropped. We had very little influenza initially in the COVID-19 pandemic in the US, suggesting how effective it is wearing masks and washing hands and reducing a respiratory illness. So I really appreciate what this individual is saying, particularly in individuals who haven't been vaccinated or have not gotten their booster with with the variant Omicron. We really want to make sure that all of the measures that we know that can prevent a respiratory illness, which is exactly what this person was saying, covering your mouth with a mask, particularly when you're indoors or in a crowded space, washing hands and keeping distance, physical distance, we know works well and is effective in preventing a respiratory infection.
Thank you. You mentioned that right now we only 2% of the COVID variants is Omicron, and eventually, apparently, it's gonna go like be a dominant variant. Is there anything being doing right now about the vaccine? Because you also mentioned that people who have been vaccinated can get Omicron, and but unfortunately, it's not as dangerous so far as the previous variants. So the new vaccines or the third 4 doses that we're receiving, are there going to be change? Are there going to be something to add something about Omicron?
Well, the evidence suggests that having the booster vaccine is very effective, can bring you back up to those very high effectiveness numbers when exposed to the Omicron variant. So before I would even say recommending the booster, getting fully vaccinated is very important. For those who are fully vaccinated, getting a booster is a key part of preventing getting Omicron infection. But as well, there's probably evidence to suggest that if you have a vaccine, it decreases the risk of post-COVID symptom, the long haul, the post-acute symptoms. So it's very important. As of now, Dr. Fauci, who runs the NIAID branch, is recommending that we don't need modifications. I know that some of the companies are looking at variant-specific vaccines, but the evidence suggests that right now being fully vaccinated plus a booster has excellent protection against Omicron. The 3 doses are very important in reducing the worst outcomes, hospitalization and death.
Thank you. I also heard in one webinar that I attended that there's project or about something like creating a pan-coronavirus vaccine that will cover every variant, whoever variant that appears afterwards. Is it true? Do you know anything about it?
That's an interesting question, and I'll have to get back to you because I don't know the answer to that. But I think what I can say is that no one is surprised by the appearance of variants because it's a natural process of evolution. But what it does tell us is that the need to have global delivery, not just of making the vaccine, but getting the vaccine into people is critical because we are not safe until every person is safe.
Can you elaborate more? Can you elaborate more on what is meant when we say that this variant is more contagious but less virulent? What does it mean?
So what that means is that the variant can spread to more people from one person. And we're learning a lot more about transmission. So we're really now, 3 weeks or so into this new variant. So we need more information. And there was a study that came out just this week from Hong Kong that looked at the amount of shedding or production of the virus in the lung tree. And so, the question is, does this variant replicate more quickly, in a shorter amount of time, producing more viral level, but is mild? So it's actually, people are able, from an evolutionary standpoint, it makes a lot of sense from the standpoint of the virus, because it doesn't necessarily kill the individual, but they're able to go out and about and spread it broadly. And so from the virus standpoint, it's very effective in spreading broadly. So that's what it means when it is more transmissible, meaning instead of one person affecting 2 people, or in the case of the Delta, 5 people, it would be even more than that, but that the cases may be more mild, like runny nose, flu-like symptoms.
That was another question. So, are symptoms of Omicron different to the Beta or the Delta or any other variant, or the same?
We still don't know how. There's information emerging from South Africa, this case report that I mentioned from the MMWR this week, that seems to say that cases are more mild, but these are still small studies. So we need larger population studies to be able to say that more convincingly.
So there is a possibility that the Omicron continued changing and became more violent or more dangerous than the other ones. Is it possible?
Or there may be just a new variant that comes up that's not Omicron.
Is there any treatment available outside vaccines to help against this variant or any other one?
Well, there are 3 monoclonal antibodies that have authorization from the Federal Drug Administration, the FDA. Those are in infusion through intravenous infusion. And there are more efforts for mobile vans, mobile clinics to be able to offer this kind of treatment. Those kinds of treatments show effect in decreasing the risk of hospitalization. There is concern that some of those treatments may be less effective in Omicron, but we don't know yet fully.
There's a question that should I be concerned about Omicron infection if I already had coronavirus and already get vaccinated?
Yes, there is evidence that if you are fully vaccinated, it is still possible to be infected with Omicron, though those cases seem to be mild, but there are individuals who have been vaccinated and are hospitalized, and more of those cases are related to people who had underlying health problems. And it is possible that you can get reinfection. There are cases of individuals who even had the Delta infection from Delta, who then got better and then got infected with Omicron. So it seems that there is this viral mutation does have a way of likely escaping the immune system in a way that was different in the prior viral forms.
So there's definitely possibility of another variant coming up.
Yes, we would anticipate this virus will continue to change over time. We should remember flu virus, the influenza virus changes every year. And so that's why we have there are different strains, and every year individuals are encouraged to get a vaccine so that every year the vaccine can be updated. We don't know yet how whether the COVID-19 vaccines will have to be modified or not in that same sort of style. But what I mean to say is we anticipate that viruses will change over time.
Okay, so this person, Kayona Davis, she says like, being vaccinated with booster protect us from Delta. We know that. It's the same with Omicron, the booster?
Well, the booster is really important in preventing infection. We're in learning more. We're going to have more evidence over time, but it seems to be most important in preventing hospitalizations and deaths.
Okay. What can we do to avoid this variant besides getting vaccinated? Well, I think you mentioned something that we have to see promote, same thing that we did at the beginning.
Right, it's the same story, but I think our voices in some, we're 2 years into this pandemic and decades into HIV, and it only emphasizes how important the relationships are between all of us in working together, because it's a very similar story from when I think about Omicron, it just emphasizes the importance of public health and social justice and campaigns that are really working against the structural roots of inequity. So meaning fairer, more healthy workplace conditions, laws that promote the health of families, that don't separate children from their parents, access to immunization and other kinds of prevention and food programs and so forth. So they're really about improving our public health infrastructure. And the better that we can do in bringing public health and vaccines into communities, into schools, that's really our best bet in terms of preventing the impact of Omicron, and as well addressing mental health. One of the things that was so powerful in working in the COVID-19 response in our city of Chelsea, we would have a pandemic call every day, and it had over 100 people who would sign in, and we dealt with really the whole person. There was someone who gave an update on religion, someone gave an update on how people were doing with food, someone gave an update on what the situation was with schools. So it is really thinking of this as integration and HIV care. I mean, HIV care has not gone away. These are still elements that are so important.
We have seen an increase of mental health issues and also substance abuse problems during the pandemic, and I think it's related to the fact that we are all kind of depressed and anxious, not knowing what to do, what's going to happen in the future, right? So what you mentioned about the holistic approach to the patients or the community is very important, and I think that's what our organizations in the city and in the country are doing, trying to do with the help of the government. Mm-hmm. So I want to ask the audience, if you have any more questions, please write it in the Q&A or in the chat where I can read it. So I don't have any more questions. I think you answered my questions as well. Terrell also asked, so let's wait a few minutes to see if anybody has.
Sure, and while we're waiting for questions, I just want to express really my deep thanks for everyone who is on the call for all the work that they're doing in their communities to care for one another, to work against stigma in all sorts of levels, to help one another, because I'm thinking, Luis, about the comment that you just made about mental health. I mean, the social isolation has been so deep and powerful, and we're finding new ways really of connecting and helping one another. And so I'm just so thankful to everyone on the call for all the work that they're doing and what we're learning from one another.
And you mentioned stigma also, and it brings me to HIV field, right? HIV-related stigma. Some people don't want to be tested, because they don't want to be related to HIV or to the populations that are affected by HIV. In terms of COVID, there's also some certain stigma. Like if you are positive for COVID, people don't want to be with you. But if you don't wear a mask, or if you wear a mask, if you cough on the streets, many symptoms and signs that people start pointing at people for doing or not doing something. And it's also a problem with COVID.
Mhm.
So as a society, I think we tend to create these things like stigmas. There's a question here. With the emergence of new variants, have we seen a change of attitudes regarding vaccines?
Over time, as there's been more information, I've worked with Terrell's organization, the COVID-19 Prevention Network, to try to bring education into local communities settings to really understand population concerns. And over time, we have seen more acceptance of the virus. I'm sorry, of the vaccine, but there still remains a lot of barriers to getting the vaccine. And a lot of those barriers are beyond just beliefs, but include getting the vaccine to really where people are, the structural kind of barriers. There is, about 25% of the population that hasn't been vaccinated yet. And there are many reasons why those exist. And it just underscores, to your point, Luis, about stigma, it underscores the importance of really trying to understand one another and sort of step into one another's experience. We may not agree, but it is really helpful to try to understand. And as a physician, saying I'm here and ready to help once someone is ready. But you're right that there is a long tradition of labeling or using names to categorize certain individuals who, are unvaccinated but we really need to do a better job of understanding those concerns so that we can do what we know really works, which is getting this vaccine into everyone.
Yeah, sometimes other needs are more important. They get vaccinated for these people. Like the person that worked here in the laundromat downstairs, she didn't get vaccinated because she couldn't stop working. She needed to work because she needed money for her family. And it was like something that no one of us can understand. No, we are not her. She knows her needs more than us. So is there a sense that we will be dealing with variants every year, like influenza?
I think what we can say is that the better job that we can do in reducing the virus on the globe, it reduces the risk of variants. But the normal process, as long as there is virus that is in the community, it will, if there's enough virus, it will evolve over time. We don't know how frequently these variants will emerge or what the requirement yet will be for example, annual vaccination. We don't have information yet on that. And partly it will be being able to follow individuals over time and seeing how the immune system also does, having received the vaccine, how is the immune system able to remain strong against SARS-CoV-2, or will it need to have a boost or an additional vaccination?
Yeah, I was vaccinated in March. I got my booster in September, and I think I got 4 doses in April. I read my records. So is it going to be a fifth? It's going to be 1 a year? We don't know yet.
We don't know yet.
Yeah.
But that, the wonderful thing about having these kind of webinars is that I always promise I'll say what I know and I don't know. And this is an area that we need more information on. And I'd love to be able to come back later on and tell you what we do know more, but we don't know yet about what the requirement will be for the frequency. But it is very common in infectious disease, vaccines to need a booster. If we think about the HPV vaccine, or we think about the tetanus vaccine, we think about the measles, mumps, and rubella vaccine, it's common, or hepatitis B, it's common to need more than 1 dose. So the question really will be moving forward, what will that look like for COVID?
For people who with underlying conditions that prevent them from being vaccinated, are there alternative measures that can be taken for them to be safe?
I would, so there are very few reasons that one couldn't get a COVID-19 vaccine. I mean, the main reason would be a severe allergic reaction to for example, a prior mRNA vaccination. So particularly in individuals who have what we call comorbid conditions, individuals who have or have an immune impairment, We particularly want them to be able to get vaccinated to prevent the more serious outcomes. We especially want individuals who are exposed, essential workers, to be able to get vaccinated. So I would just kind of change that question or modify it in a little bit to say that there are very few reasons that someone would be excluded from getting a vaccine. And I think what the latter part was about alternative treatments, was it, or alternative?
For the people who cannot be vaccinated, what can we do?
Yeah, just, for the small group of people who could not be vaccinated for a reason that their physician thought was important, it would be doing the things we talked about in the beginning, like masking, hand washing, distancing. And there is more information that's coming down the line about potential medication, like we have HIV post-exposure prophylaxis or pre-exposure prophylaxis, whether there may be medication that someone could take if they have been exposed and are at high risk for SARS-CoV-2.
Yes, just a comment, you mentioned like, we don't know, we are learning through the process with the pandemic happening, we're continuing learning. And that brought me to the first pandemic, or even the pre-pandemia webinars that we're doing before calling pandemia, when we didn't know anything. We were trying to enroll people in studies. So we have our presentation of Latinos and Hispanic in the study, how important it was. And now, after 10 or 12 webinars that we do, we know a lot more, and we know about vaccines, and we know the variants and why they happen and what's happening. So the question, when they ask you about it and you say, we don't know, I think it's true. It's like we are learning. It says, Lucy Vega, thank you, Dr. Levy, some great information. Thank you so much for putting together something great as always. Enjoy your holiday, everyone safe. Yes, we're about to finish.
I wanted to thank everyone for asking questions, because it is so important to ask questions. There is no question that is silly or stupid. They're all important. And when someone asks me a question, a patient, I think, it is so important to be able to answer someone's questions. In fact, before I got the COVID-19 vaccine, I'm an infectious disease physician. I wanted my questions answered, and I wanted to learn a lot. So I think all of the questions that people are bringing today are so important. And it's so important, Luis, that you're doing these webinars so that we can continue to ask questions. We never want to be satisfied. We want to keep asking so that we'll learn more and feel more comfortable.
And everything that we today are true, maybe tomorrow want to change. Okay?
Right.
Yeah. So we continue to bring information and actual information to you, the community, and the people who work for the community. And we will continue with this, with the prevention network, community prevention network, bringing more pandemia episodes next year, I'm sure, until this disappears completely. So thank you, Dr. Levison, very much for being with us today and share your expertise and your knowledge on the field. Thank you, everybody, for being with us, and happy holidays for everybody, and see you next year.
Thank you. Muchísimas gracias.
Gracias.